to the platform of the Swiss Liver Patients Association, Swiss HEPA. Today's digital talk with the 10 questions and answers about visceral and tumor surgery with Professor Peter Schemmer. Let's start with the first question. What are the main indications for visceral surgery in tumor patients?
Well, visceral surgery per se is a huge field and requires broad knowledge because there are many, many organs that needs to be addressed, starting with the thyroid, then the esophagus, the stomach, liver, pancreas, foregut, adrenals, the colon, rectum, and so forth. And basically, the most indication in tumor surgery is the entity of adenocarcinoma. And adenocarcinoma can, be developing in almost every organ. And therefore, it is the most frequent indication for resection. And for this cancer, resection is allowed or supposed if you can achieve cure for the patient. And nowadays, the cure is manageable with preoperative and also postoperative chemotherapy in many cases. And therefore, it's not just the surgeon who is curing the patient, is more than that. It's the oncologist, and for getting the diagnosis, it's the radiologist, and there's a whole team and nursing, and so it's a rather complex field. And again, the major indication is to cure the patient and not to just resect tumors for palliation. And the difference between cure and palliation is that, of course, you have a long-term survival if you cure the patient, most likely tumor-free, and palliation is the opposite. There is a certain time period that the patient can still be alive, but the tumor will not vanish. And do major surgery for palliation, it's not clever, it's not wise.
Okay, so if you have to kind of decide between curative or palliative surgical approaches in cancer patients, so how can you do the decision?
Yeah, it's always a good question and sometimes even a difficult question. Decision-making process is complex and includes, to assess the patient very careful. How healthy is the patient up front? Is surgery allowed, or is it too risky for a patient? This is number one question. Number two is, the imaging of the tumor, of the diseased organ, whether or not a surgeon can actually resect this tumor as a whole. That the resectional margins are tumor-free, and there's a certain, gap between the edge of the tumor and the healthy tissue. So this needs to be addressed up front, and then you can have the indication for tumor resection or not. Number one, the patient is suitable for surgery. Number two is that the tumor can be resected totally for cure. Sometimes, as I stated before, palliation is needed, and also a surgeon is needed sometimes for palliation. In the case of there's a bleeding, for instance, dramatic bleeding, and you just can preserve the patient's life if you go into the abdomen and stop the bleed. Number one. Number two is if you have a tumor that is obstructing the foregut or the colon, and the patient cannot eat anymore. The whatever the patient has been eating, cannot pass through the intestinal system, then surgery may be needed for, decompression of the gut. And then most of the time you have a stoma of the small intestine or of the colon.
Okay, thank you very much. So you have also always kind of a risk of recurrence risk, and kind of what are your principles of oncologic resection? So how kind of do you resect it?
Mm-hmm. Well, the surgical oncology requires that you fully resect the tumor and you take all the supporting vessels together with the tumor. And therefore, together with the vessels comes the lymphatic system. So you clean the lymphatic system with all the lymph nodes that are, in the way towards the tumor. And this is surgical oncology. And otherwise, you only resect the tumor, and this is just not enough because most of the time the tumor has been spreading out for metastases, and the first metastases that are there are in the lymphatic system.
Okay, so there's always a risk kind of before you start the operation, and you have to manage this. So, and you have to remove what is bad and just kind of save everything good. So it's very, very tricky. It seems like, how do you deal with this? How do you evaluate with this process?
Yeah. Well, there are standards in the evaluation in terms of you have to have X-rays taken, specifically CT scans of the organ, of the environment of the organ, but also to other organ systems. For instance, if you have a tumor in the abdomen, then you have to have a CT scan of the chest to rule out metastasis to the lung, or to any other body parts, sometimes even to the brain, to exclude metastatic disease that you either have to address in a second step surgery, or you say, okay, this is not resectable and therefore it's palliation. Palliation most of time does not include surgery, but one has to talk carefully with the oncologist. Sometimes it makes sense to combine, even in those cases, chemotherapy plus surgery, because sometimes the metastases respond to chemotherapy very well, and this makes tumors resectable that wouldn't have been resectable without chemotherapy.
So there's always kind of these decisions that come as well, some complications as well. So what are the most common complications of these surgeries and how are they managed?
Well, I mean, it really depends on the organs you have to address. Complications after surgery include, no matter what organ you address, uh, bleeding from the surgical site, um, lung embolism, thrombosis, sometimes, leakage of the connections you have sewn. If you, for instance, take a part of the colon out, of the small intestine out, you have to combine the two ends again. And, there's a healing process. And if the healing process doesn't work very good in some of the very, very sick patients, then you have a leak. And with these kind of leaks, you can address them very easy. You can put in drains to sort of dry the surrounding area to prevent further infection, or if this doesn't help, together with antibiotics, you can go into the abdomen again and to just do it again. And hopefully then the healing process is okay. Bleeding, as I said, can come from anywhere in the surgical field. Most of the time, we operate with very, very minor blood loss because this is due to the modern resection techniques. but sometimes, specifically in patients who have drugs with them that thin the blood, that prevent coagulation because they have heart disease and something like this, then the incidence of a rebleed after surgery is increased. But again, this can be managed. And if you see the benefit and calculate the benefit to the risk of bleed, of thrombosis and whatever, then the patient must benefit of the surgery, and the risk must be much lower than the benefit. And then you go into surgery.
Okay. So there are like kind of two cancer types. I would be interested to know a bit about colorectal cancer and also the pancreatic cancer, how it's managed, yeah, and how you approach these
Okay.
kind of cancers, because it's also a field.
Yeah. Well, colorectal cancer is, well, it's a malignant disease. This is clear. And the chances of long-term survival over any stage of the disease, more or less, is much better than pancreatic cancer. So this needs to be stated up front. And in both entities, surgical resection is the major part uh, for acquiring cure of the patient. In both entities, most of the time, at least after surgery, chemotherapy is needed, because then the long-term outcome is improved. So coming to the colon cancer, you have the staging up front. You have a colonoscopy, most of the cases. You have most of the cases a biopsy taken, the proof of the tumor, of the cancer, and then you have the staging. This is imaging of the abdomen, number one, and number two, of the chest, of the lungs. And if you have here no metastatic disease, then you can resect the tumor. You have to resect the tumor unless the tumor goes right into many, many other organs, including vessels and so forth. And then you have to be very careful how far you can expand and how aggressive you can plan the surgery. And this depends pretty much on the age and of the otherwise health of the patient. If there is metastatic disease, you have to think of, okay, can you resect for instance, liver or lung metastasis easily? Then you do most of the time the primary cancer, you resect this first, and then secondary the lungs or the liver. If the liver metastases are critical in terms of if there is further growth, then the patient cannot be treated anymore for cure, then you go for the liver first and do the primary cancer as a second operation. So this needs to be thought of very carefully. In pancreatic cancer, it's a bit different because in most of the cases, the patient doesn't feel the cancer. It comes very late that it's symptomatic. And the symptoms are, if the patient is lucky, the patient becomes yellow. And this comes very early. So if the pancreatic head is involved, where the bile duct goes through, then the tumor can compress the bile duct, and therefore you have a yellow eye, and the skin starts to itch. And this is more or less early symptoms. And then if you can locally resect the tumor, then you do so. But before that, you have to do the staging again. And only in rare cases, in very rare cases, in very young patients, you even can resect the tumor if there is metastatic disease. But then, specifically in these cases, you should really go for neoadjuvant chemotherapy. This is chemotherapy before resection to see whether the tumor is responding. And this is also good for patients who have a local disease that is not in the beginning anymore. If the tumor is big, the vessels are encirculated or even infiltrated, then you should have the neoadjuvant chemotherapy and see how the tumor is responding. And if the tumor is responding, and for instance, the vessels are freed from tumor and so forth, then you have an indication for resection. Otherwise, the prognosis may be so bad that you really cannot help with surgery.
So there's always to find kind of between you do chemio or not, you do surgery or not, or you combine. There's always a bit, every case is a bit different. Is it?
Right.
Yeah.
And for this, and therefore, specifically in the modern oncology or surgical oncology, you have to have a team with experts that is, talking to each other for the specific case, what to do and when to do. And for instance, also when to stop the chemotherapy and to do the resection or just do only chemotherapy for palliation or whatever. So the experts are really needed. And I think the surgeon should be also included very early in the decision-making process because there is a time point when the patient may become resectable, and this a surgeon can tell and no one else.
Okay. So it needs a whole team for the
It needs a team, right. And the team is, as a standard, it's oncologist, it's a surgeon, it's even a radio therapist, and it's the diagnostic team, radiologist, interventionalist, gastroenterologist, and many more. So you see, it's really a big team because the possibilities today are very wide to combine all of these measures to have the best possible outcome for the very patient.
Yeah, I can imagine that it can be very difficult. And as well, if you have a patient who has already an illness and you have kind of to protect this organ or whatever where the illness is, plus get rid of the cancer, it can be very, very tricky.
Right. So, in the past, it was just the surgeon or just the oncologist, but now it must be the whole team for best decision making.
Yeah. So when, if you, for example, let's talk about the post-operative surveillance. How is it conducted? Is it also by the team? And what is, for example, your work afterwards?
Yeah. So the question was, I didn't get.
Kind of if after these operations and
Yeah. Okay.
teammate, kind of how does it work, this process? How do you kind of look after the patient? What
Yeah.
is going on in the process, kind of
Yeah.
operative?
Yeah. Well, most of the time, this is the task of the oncologist together with the radiologist. So it's imaging. And there's more or less a standard for the diseases of the very organs in the national guidelines, the international guidelines. So it's pretty much well defined. And in most cases, it's the oncologist who is taking care of this. And again, if if you have the circumstances that you start with chemotherapy as palliation or as a near-event setting, there must be after 2, 3 treatment episodes, the surgeon involved to get his idea included in whether or not it's the right time to do a resection even, or just to go for permanent chemotherapy. So this is always a good idea. But again, the surveillance after resection, this is oncologist together with radiologist, and this is good because they can see early most of time whether this recurrent disease, and if there's recurrent disease, the patient is discussed in a tumor board where all the potential physicians treating the very patients are included, and then again treatment will be discussed.
Okay, thank you very much. Before we move to the patient's questions, would you like to add something else, or which you would think it's very important to know for us patients?
Well, I think it is very important, and this is my experience or was my experience in Germany, was in Austria, and now is in Switzerland, is that modern oncology and modern surgical oncology can achieve very much. And it's always my impression that physicians give up too early, or maybe patients give up too early because they fear whatever chemotherapy is, whatever resection or whatever surgery may cause. And I think it's always a good idea to send patients to the specialists getting their ideas. And then you can still go for, okay, risk of surgery and benefit of surgery. And if the balance is not good for surgery, then you stay away from surgery. And the same is true for chemotherapy. Many patients come and say, oh, never, I do never chemotherapy. And I say, why? Loss of hair, I can't go from out of bed anymore because I'm weak, there's vomiting, nausea, and whatever. And I say, well, listen, this may not be the chemotherapy you need. And even though you would need this type of chemotherapy, then you don't know whether you really get these symptoms. So just wait for it and give it a try, because trying something doesn't mean that you have to complete the whole circle of treatment. And this is something that sometimes astonishes patients and even colleagues who are not so in the field. So I always say, just go to the specialist and get a second or even third opinion.
Okay, so really trust the person, the specialist, trust also the process, and hope for the best, and also try everything which is possible. You
Right.
suggest, no?
Yeah.
Okay. Yeah. So that's a very good point. Thank you very much. So let's move to the patient's questions. So there is a patient who is kind of asking, what are the risks and possible complications of a surgery? Like when they really decide, okay, let's do the surgery, let's try it. What could kind of be a complication in general?
Well, this is always a difficult question. There are, of course, general complications there are complications that are possible in many types of surgery. This is thrombosis, embolism of the lung, bleeding, wound infection, deep wound infection, leakage of anything that we have been sewing together. But this question cannot be answered sufficiently, because you have to talk to the individual to see, okay, how he or she is performing right now. Is he or she is, what is the health,
Yeah.
and what is the muscle mass, and there are so many factors that needs to be addressed up front to actually see how high is the risk in this very patient. And many patients fear that the surgeons or whoever is treating just goes for it, and if he or she starts with treatment, then, it's just a tumor that needs to be killed no matter what it takes. Well, to be honest, this is the past. Nowadays, we talk to the patients. We really want to know what their aims are, how far they want to be going, for the treatment. And, the next fear is, okay, there was surgery and then I'm unconscious and, they do whatever is needed on the ICU. I'm ventilated, the kidneys may be failing, then there's a dialysis and so forth. This is nothing we really want to do because we all do this. This is correct. But there must be a goal that can be achieved. And this is, having the patient going out of the hospital, being treated, and or maybe even being cured. And if the goal cannot be achieved, then there will be no dialysis, there will be no long-term ventilation, because we sort of have then the more or less end-of-life situation. And this must be this must be clear. And in many patients, there have been some, written letters stating, okay, I want to have this, 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 and this, and not more. Of course, this needs to be addressed. In terms of what I've been saying, it must make sense if we do the dialysis and so forth. But if it doesn't make sense for the long-term survival, then, we just don't do it.
Okay, so you kind of need the chance of long-term survival to do like every possible.
Yeah. You
Yeah.
don't ventilate the patient for like a year or so without a final goal that he or she comes off the ventilation. If this goal cannot be achieved, then you just don't do it. Then, then it's organ failure, and organ failure is well defined, and this is not related to a long-term life or a good life. But again, these things have to be discussed carefully together with the patient and together with family of the patient.
Okay. So it can be that, for example, after a surgery, a person gets a stomach and there will be some permanent changes to the body, for example. And what kind of changes could it be, for example, for a patient, they ask?
Yeah. Well, most of the time, if there is a stoma involved, uh, there's a great chance to get the stoma back, with the second operation. If that cannot be achieved, then there is a permanent stoma, and most of the patient can deal with that situation very well. They are trained to get along, to come along with the stoma, and then they do have a normal life. There are other things, again, the issue of ventilation after surgery. For instance, some patients acquire pneumonia and they can hardly breathe, and then they're ventilated for 2 or 3 days and they come off the ventilator and everything is okay again. So this is something else that needs to be addressed, because some patients say up front, no, ventilation, I don't want to have this.
Mm-hmm.
And this is sometimes not a good decision, because after 2 or 3 days, problems can be solved with ventilation. But if they refuse up front, then you have a dilemma, because you could cure the patient, but he or she doesn't want to be ventilated, and then you have a problem. So this needs to be addressed before surgery, and we do.
So kind of if you can treat it for a short term and then the patient gets kind of back to normal, it is advised to do all these things actually.
And before I get an informed consent for surgery, the patients, together with family, if they want, are, I talk to them not many hours, but 1 or 2 hours at least, to have them in the situation that they can follow whatever I suggest. And every complication that can be, coming after surgery, I address by name and I state, okay, if this occurs, then we have this, 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 and this as to solve the problem. And then they understand and say, oh, that's okay. So there is a standard of getting rid of the problem. For instance, for 2 weeks, I did have a patient who did have a complication. It was a minor complication. I explained the complication to him, and he said, oh, okay. So we have been talking about this before. Now you do this and this, right? I said, yes, exactly. That's what we are doing. And then the patient left hospital 3 days after.
So it's very important actually to talk to the patient and to explain everything and take time, also kind of to remove all these worries and also if they're very afraid of everything. So important to give them some support and
Yeah.
explain.
Right. And patients or everyone is afraid of something he or she doesn't understand. And what I want to have is a patient who understands the treatment, who understands the potential complications, and who understands the treatment of the potential complications. This is very, very important because only in this situation a patient can refuse surgery or can say, okay, this treatment, this is something I want to have, because the option to be cured, I agree with the surgery. Otherwise, how can you say, okay, I go for surgery or I don't go for surgery if you don't know what surgery means?
That's very true. And I think this is also very helpful for us patients if a
Right,
doctor takes the time and explains to us. So we are, as a patient, you're also ready to do more when someone takes their time to explain everything.
right. And therefore, patients should be transferred to specialists. And if the patient, after this kind of information, says, well, no, this is something I don't want, then that's okay, you know. But otherwise, I think it's bad because they give up too early because of their fear.
Yeah, that's true.
They're afraid for what they don't know.
Yeah, exactly. Everything you don't know makes you afraid in a way. That's true. With these questions and answers, we have concluded today's digital talk about visceral and tumor surgery, and I would like to thank Professor Schemmer. We are happy to be here for you at www.swisshepa.org and would be happy to inform you about further videos. Or register for the next Swiss Liver Day at www.lebertalk.ch. We wish you a good time with the best possible health.